you have listened to a number of lectures, but some of you have also presented some cases, so we will go ahead with these.
The first, we'll start from the beginning. The first case is by Dr. Nicolaides. Yes, I am right. I don't remember the name for all of you, but this name is quite difficult to forget.
Family of?
No family relation. That's better than way.
Perhaps I am trying to find it for you.
I think I know where it is.
You know? Okay.
Yeah, I think so.
Go on.
I think so.
So you have
Let's see.
Nicolaides, not
Nicolaides. Yes, well, it depends on how you
From
spell
Norway.
it. Actually, from Sweden. I'll go here. Let's see, start up here. Okay. This is not a difficult case. As I said, I work in a private practice in the south of Norway, just 100 kilometers south of Oslo, and I have all kinds of patients coming in. They're not referred. This is a private practice, no research facility, nothing like that. And this case, she came in because basically she worried about the pregnancy. That's the way it is in Norway. Because she's 29 years old, she's not entitled to an early ultrasound. Otherwise, she had a previous pregnancy, was completely normal. Now she was 11 weeks and 4 days. As I said, the diagnosis is not difficult, but I think the pictures are quite illustrative to the case. So, first of all, of course, abdominal ultrasound. And the first picture we got was the 2D longitudinal view, where, straight away, of course, the profile is quite typical for the case. And you can see the absence of a cranium, and also, of course, the brain material above the orbit. Now, doing a lot of 3D, of course, I have to render it. And it looks like this small man with his little hat on top of the head with the brain material, again, clearly visible above the orbit, and as you can see, there's basically nothing covering the skull except the brain matter. So I also had to do a longitudinal view. This is simply just to be able to look at it and try to explain to the patient who was completely unaware of the condition, never heard of it before, and just looking at the skull and seeing the amorphous matter on top of it. This is just a fun case to present, just to show you how sometimes it could be so extremely easy. I sent it off to the hospital in Oslo. Of course, did nothing else than confirm the diagnosis. The pregnancy was terminated a couple of days later, and she's now pregnant again in a normal pregnancy. And that's about it.
I have a question for the audience. There is someone here that knows what is the etiology of this particular case?
I will show you.
Amniotic band, exactly. Most probably, I'm not completely sure, but if you go back in the images, you see that something is here. This is not the placenta. Something is here, this Y, and you see here also. So maybe a case of amniotic band that having described as producing an encephaly. Now we have a second presentation. Will you please identify yourself? I know that not Coralia. There is another one that is willing to present. I don't know the name. Raise your hand who is going to present.
I have to present, but it's not in a brain case.
Okay, yes, come on.
Sure. select the brain case, so I said it's not the brain.
No, okay. You know what it is?
I hope so.
Okay.
Yeah, it's here. Okay, this is a case of megacystis. I have to go. Is a 36 years old first pregnancy that came to Mount Sinai Hospital at 14 weeks and 5 days. She's a healthy patient with no habits, and she had no previous history, significant history. She had a previous first ultrasound at 9 weeks just for dating, and during the ultrasound for NT at 12 weeks, a megacystis was seen. We didn't have the real measurement because in Canada you just receive the reports and not the images. So it was a generic megacystis with an NT of 2.74 millimeters, and this is why she was referred. And these are the images. So the fetus was completely stuck with enormous bladder. As you can see, it's like 5 centimeter over 32 millimeters. And it was very difficult to perform the scan because the fetus was just fixed in that position. And this is what we get with the transvaginal probe. And we saw the 2 kidneys. One is I don't know if I can show you something. Anyways, on the right side, on the left side, you can see a dilatation of the left kidney, and the right one was normal, apparently. We saw other malformation associated. We saw a 2-vessel cord, confirmed also in the transverse view of the cord and not only around the bladder. And looking at the brain, at the face and the brain, we saw a cleft lip and palate. It was more on the left side. The conclusion of the case is that we presented all the options to the patient. The patient decided to interrupt the pregnancy immediately after. I unfortunately have only the QF-PCR that was normal. The microarray is still pending, is a recent case, and unfortunately the microarray, of course, they gave priority to the live cases and not a case of TOP. The pathology reports, when I just left from, they confirmed kidney dysplasia, and they didn't mention anything about the cleft palate, but my suspicion is that because the patient decided for a termination with D&E, so the material was not really the best to do a complete autopsy. This is the case.
But was the kidney dysplasia that you see following a megacystis?
Yeah, exactly. So I think that is probably more, I mean, with a big cyst, with a big bladder like this, probably can be a Luto case, but...
Was it a posterior urethral valve or a urethral atresia?
Exactly. This can be both. I mean, probably so early can be a urethral dysplasia, so a Luto case, I think. Thank you.
So in pregnancy, it's difficult to make the differential diagnosis, but if you see a case like this one at 20-21 week of pregnancy or later on, with normal amount of amniotic fluid, the diagnosis is completely different. It's a case of macrocystic microcolon intestinal hypoperistaltic syndrome that is an autosomal recessive condition, so it's important to know. A girl. It's a girl. Maybe also in boys also. It's autosomal recessive. Thank you.
Thank you.
We have for every one of the participants this year, we have something for you from ISUOG. Dr. Nicolaides is there, he will come. Now, the next case will be presented by Coralie and Horn. Yes, she will present one now and one after lunch. Go on. Next time, it's good to come and present cases because you have presence.
So fortunately will work because my first case has some movies who didn't work for now. So my first case for today is was diagnosed and follow up by me and by my colleague, Dr. Eduard Balasha. And we had a 20-year-old patient with no previous medical history at her first pregnancy. The first trimester scan was absolutely normal, but in 16 weeks, we diagnosed something like this, for which first believe it was a teratoma or another kind of tumor. Later in pregnancy, for the second trimester morphological scan, we have this movie. And
So, someone is willing to make an attempt. No, you
no.
don't play.
without you, sorry.
Sit and remain quiet, please. Your mother always used to tell you, sit and remain quiet, Rabbi. Someone else? What do you see? Describe what you see. How many?
Actually, in the first picture, it's quite easy. The brain looks absolutely normal.
No, look at the face. There is something that is very so uncommon that you are not expecting to see. Go on with the next one.
I think the picture is more accurate than the movie.
Go on.
Because, okay, I'll go with the diagnosis. So the diagnosis is the lateral proboscis. It is called also heminasal proboscis or lateral nasal proboscis. In fact, it's a quite rare pathology and affects especially the male. It's a rudimentary tubular nose-like structure ranging from 2 centimeters long and 1 centimeter in diameter, and is located off-center from the vertical midline of the face. Most of the cases arising from the medial portion of the orbital roof. It is club-shaped distally and usually contains an internal canal that traverses the entire proboscis and ends proximally in a cul-de-sac. Sporadically is an isolated defect, usually is seen in association with a wide spectrum of other abnormalities, especially for the cranial parts, involving the eyes, the facial bones, the nose, the face, and the brain. In our case, the baby boy was absolutely normal neurological development, but he has only 1 kidney. The most known classification, it belongs to KU, and our case, it was diagnosed in the group 2, and it's possible to make an early ultrasound diagnosis and of course to have a proper counseling, because usually the normal development is fortunately absolutely without any other implication if is there no brain abnormality. The first pictures is immediately after the delivery, and the second one I received a few days ago after the first stage of the plastic reconstructive surgery. Thank you.
Thank you. And I have a question. The brain after delivery, brain MR is normal?
Absolutely normal. Absolutely normal. So he was delivered in Romania, but treated in plastic surgery in Italy, and they also perform or the MRI scan. So it's absolutely normal, but only 1 kidney.
You should receive 2, but this is at least 1. Sarah is making problems. Thank you. And the last case, Tzalel, Dr. Professor Tzalel from Israel, I will give you because I know it's very good. So,
Can you take down the lights, please? This is a case taken at 15 weeks plus 6 days by Dr. Miki Lurian, who is sitting among us today. What do you think about this image? Hypertelorism. How do you know that it's a hypertelorism? 15 plus 6 days. It's the interorbital diameter is 1.2 centimeter. So we go to the literature, to the tables, and what we see there are two articles, one by Budorick and the other one by Eberhard Merz, and you can see that 12 millimeter of IOD is above 95th percentile to this gestational age. So this case is presented as a hypertelorism, as an early sign of callosal dysgenesis. This is a 29 years old G1P1, early scan, as I said, suspected hypertelorism by Dr. Lorian. Her physician examined the husband and interpreted it as a physiological, as a familial finding. And then she came for late anomaly scan. And this, what we saw at the late anomaly scan, as you can see here, you can see the hypertelorism here, and you can see the dysgenesis of the corpus callosum. You can see the thick corpus callosum, and you can see the dysgenesis, especially in the posterior part of the corpus callosum. A few words about development of the eyes. In the primitive face, the eyes are placed laterally towards panoramic vision, and as gestation progresses, they migrate towards the midline for the stereoscopic vision. Hypertelorism is an increased interorbital diameter. In the mild cases, it is a common variant, familial. Severe cases could be with median cleft face syndrome, craniosynostosis like Appert, Curzon, Pfeiffer, agenesis of the corpus callosum, and anterior encephalocele cell. And I did a search toward this session. This is a partial literature review, and all cases here you can see partial chromosome deletion, craniosynostosis, another deletion syndrome, congenital disorders of glycosylation, Cornelia de Lange syndrome, acrocallosa syndrome, and Opitz type. All these cases were diagnosed either after 21 weeks of gestation, at birth, or many years after. And this is probably what Dr. Lorian was diagnosed, one of the few cases that was diagnosed very early in pregnancy. And this, as you can see, you can see the clip. I'm used to the, and as you can see the clip, and you can see the very dysgenetic corpus callosum. And these are the last pictures taken at 15 weeks of gestation and the 20 weeks of gestation. You can see the very prominent hypertelorism. And I thank you for your attention.
Thank you, Yaron. I will give you back your seat. And go. And now we will have some cases by Ravi. If you are in time, we will also show you some cases.
Which one would you like to see, Gustavo? So this is patient was examined by my colleague at the office, and she called me because she didn't like the fluid accumulation in the posterior fossa. 12 weeks plus 5, large stick accumulation here. This is the mid-sagittal view. You cannot ignore if someone tells you, oh, there is something. So 12, 13 weeks, she decided to go for CVS, and the CVS was normal. This is here the rendering. This one for me was rather normal than abnormal, but still, nevertheless. So what do you tell the patient? You don't know. Control. We control at 16 weeks. Come back at 16 weeks. It could be a black spot, but you can say only black spots when you see that the cerebellar vermis is normal. So it is likely, but it's not so.
Very large.
Yeah. No. Not if you tell very large, she will be very angry. You say it's large, she will be a little bit worried. Very large is very worried. Large is worried. Normal, not worried. Little bit large. So, and let's say my message was we do a CVS. In Germany, people do not do automatically an array because they have to pay for it. And they said if the foramen opens and we don't see anything, we stop there. If it's still there, you think of doing an array. I said, okay, so I rendered. Where is Gustavo? Where's sitting Gustavo? I prefer to do 3D, proper 3D. This is, for me, the developing vermis. I cannot tell you if it's the normal size, but at least I have something seen. Said, I prefer if you do an array. She decided for the array, so 16 weeks. This here is the, what is this vessel? And why I am looking to this vessel? Sorry? Pericalosa? No, come on. Come on. What is this vessel? Sorry? Straight sinus, bravo. The straight sinus has a course along the tentorium. The tentorium is the level where we look for upper tentorium for Dandy Walker. So it's not very high. For me, it is at this stage rather normal. You see here the developing cerebral vermis, and this is the Blake's pouch. 16 weeks. The upper part of the vermis is seen. 20 weeks. We see here the upper part. This is a clip, I guess. Yeah. So longitudinal view, 20 weeks. 20 weeks like this. Blake's pouch. 20 weeks. Rather, yes. 24 weeks plus 4. Still there. I was hoping to see. No. Superior rotation.
Remnant of Blake's pouch.
Yeah. Yeah, for me it's a Blake's pouch, and then now she will go for counseling for Blake's pouch and so on. So the array showed a small deletion, but the mother had the same deletion. We did the MR of the fetus, Blake's pouch, and the mother has normal vermis. So see, this is the mother, and this is the fetus with the Blake's pouch. Nice case, but 12 weeks of terror for the lady, believe me. But when we learn something, we should follow. I'm happy what Gustavo was saying, that you know what, you have to keep cool, to say, wait, please, we need to see, we do not know anything. And I'm hoping that, give me your comments. Give me your comments. What you have done different. You will do the same. Probably less control. Yeah, but you don't know. But you don't know, because if they tell you, I don't want a handicapped child, and you start, yeah, it could be, it could be, it could be.
The only problem is that the child has a rotation of the vermis while his mother has a normal vermis. So we don't know the problem is for sure.
Yeah. But let's say if you don't see anything, we'll do later on a scan for polymicrogyria and all this. Is Asma in the room? Yeah. Hi, Asma. Yesterday I asked you a question. I will show you the case because Gustavo encouraged me. When you spoke yesterday, you said that in trap sequence, half of them will have blood cessation until 17 weeks. And for me, it is, let's say, clinically similar like monochorionic, where one is dying and you may have a brain damage in the other one. But we don't have any data on TRAP. So this is a case I observed, and this is why I was worried. So I saw this lady, she was sent to me because of, second opinion for TRAP. And at that time, 14 weeks, the fetus had no blood anymore. And this is of the other one, with a slightly higher, low A wave or some higher pulsatility. So assume that this was pumped even more in the last stages. So I scanned the brain transvaginally at 14 weeks to start to look what's going on. And actually, I didn't like very much the lateral ventricle. But if you see here the whole layers, So we did an invasive procedure because the fetus, one of them had some, let's say, some kind of molar or placenta or some mesenchymal dysplasia of the placenta. But I said, you know, I want to control the brain. I didn't tell them I see something, because if you don't know what you are seeing and you don't have previous index cases, you cannot tell anything. If you say, I see this, this is abnormal, and if you are asked how many cases you have seen, never, no case, how the cases are known from the literature, 0, then it's unlikely that you are sure. So said you turn back, and this here was the same as I told you, 14 weeks, so lateral ventricle here 7.4, and then at 16 weeks, 10 millimeter. But if you see the brain here, look at this cortex, and look at this part here. 16 weeks transvaginally, this is definitely not normal. And for me, it was, let's say, the early appearance of such cortical abnormalities with one fetus disappearing and so on, is it very likely to be hypoxia, because I don't have another explanation. So it was, if I remember well, just before Christmas, we said, okay, we'll wait. And she came back January, 21 weeks of gestation, where you are used to see the brain. And you see the anterior part looks normal, and this here is almost absent. So, how do you think, has the fetus a corpus callosum?
No, in the early picture that you showed, it's like Professor Mallinger has shown us that there is no interruption
Yeah, but
by the corpus.
yeah, but in one image I will not say this. For me, I assume if there is no brain tissue, we will have less connections. So you see here, this is the dilated part. This is here the dilated subarachnoid space with the brain damage. And this is the corpus callosum, 21 weeks, 10 millimeter. There is something here, but rather secondary. MR showed the brain damage here. You see the upper part, the one you saw at 14 weeks, was there. So I'm not sure, is it an accidental finding, or is it a sequel of the cessation of blood flow with the... Yeah, logically, but we should have more. If half of them, it means it's not an... okay, so Asma, your task is now to check for the one having spontaneous cessation if we have some... You heard, Gustavo, that we are better than...
This is most probably an insult, because you have something that can explain the insult. The moment that the cardiac fetus die, the normal one continue to pass him blood, and he become anemic. And this is a clear finding in fetus that are anemic, severely anemic. You see, it's a transmantle damage. It's not only the cortical damage, but all the wall of the cerebrum is, and this all around. In some parts you see much more, but the brain becomes atrophic, the corpus callosum stops to develop, so it's clearly an ischemic condition.
So this is, since I knew today that these cases are not recorded for being later on the internet, I can show you this one. This is, for me, my best case, but I don't have time yet to publish it. My question is, where does an occipital encephalocele start? Is it here, is it here, is it here, or is it here? I have a patient, the one I showed you today, but you want to show the case. She had twice a termination of pregnancy, 25 weeks gestation, 14 weeks gestation. The first time she decided not to have anything else. The second time she decided to have a genetic examination, and the Meckel-Gruber and Bardet-Biedl were normal. Then she went to Turkey after this case. She had a scan in Germany, which was normal, and then she came back at 19 weeks because the doctor said, go back to Berlin, there is again abnormal. And it was rather, eyes were abnormal, cystic kidneys, Dandy Walker. So for me, it was typical Walker workbook. So this time she decided to have all examinations, POMT1, POMT2, and Fukuyama, and all these, they were normal. And then she, so this means pregnant, we discussed, and she had psychotherapy, and she said, when can we start to look at the brain? That as soon as you are pregnant, give me a phone call. So the nurse comes and they say, I have a phone call, and they said, okay, give her an appointment tomorrow, after tomorrow. But she's 6 weeks. That give her as soon as she gives you a phone call, let her come and we start. So this is here I showed you today. This is where we took together the decision that is abnormal, and she decided to go for termination. And this is what afterward we diagnosed as being Joubert type 14, and the parents were carrier. But this is the last control. And the control before was at 9 weeks plus 4 with this abdominal view. And it was exactly the time of the World Congress in Barcelona. So I took the volumes with me and went to Bernard Benoit. I said, you have seen a lot of fetuses, so let us sit together and work on these images. So he said, okay. He rendered this volume. He said, I see here an interruption, but I'm not sure because I don't dare to say at 9 weeks. He said, yes, it is here. It is open at 9 weeks. So, and I said, wow. I assumed an occipital one will be seen here, but it's here. But he says, yeah, it's good. And he rendered another way. Wrong. So this is here showing this. And he asked me, do you have other volumes? Yes, I have earlier. I have at 7 weeks. But so you see, at 7 weeks, it was here. 7 weeks plus 4, the first examination. And then he said, but is it not an artifact that we can render by multiplanar mode? He rendered one normal, showing the head closed, and he rendered one with the encephalocele. So in other words, the encephalocele develops from the front, going back. If you go to embryology of the vessels, this is where Markovsky describes his vein, which is going to be later on the straight sinus. So even the arteries are developing clockwise. So if you look at the posterior fossa, this is not here. You should look for, it could be here in the future. So now I'm waiting if she dared to have another pregnancy. So I will start at 5 weeks. Bon appetit. Is it now lunchtime? Did I convince you to go earlier and with 3D?
No, it's okay. It's, wait. Nice. I am afraid that this is not so.
I like it.
Look at the cute dog.
Patient has a fractured fibula. Given him, well, Saturday. So he could be able to go on tomorrow.
Daddy's gonna be so excited.
That killed him.
This is men. These are men. So I will not give you this again. Let's go. So, case 1. Yes. Okay. What do you think about this case? You will need a requester to intervene. Okay, I want to hear the diagnosis. I have a list. Go ahead. Okay, wait. I will do that in another way.
This is one fetus or several?
Okay, someone wants to speak? Now you should collaborate because you have been sitting and. No, you, Ravi, and your mother sit.
Corpus callosum, where's
Okay.
it's the
Something may be wrong.
arteries. It's not very clear. And the profile of the fetus?
No, it's
There? It's not.
It's not a good profile.
No.
It's not the profile. It's not the profile. Something is there that is wrong, but it's not the profile. Okay, what in the first image there?
Ventriculomegaly.
Very good, ventriculomegaly. What else? Okay, this one, you told interrupted with this a third ventricle that's quite high. And here, and okay,
Posterior
and
fossa.
again here you have the uninterrupted, that you say, yes. In the sagittals, the pericallosal artery goes up instead of going posterior. There are a lot of arteries here, and this one. Okay. Okay, we should see this case from here. Okay, these are the patients. These two images are 15 weeks and 4 days. Large cisterna magna, 18 weeks. Okay, apparently the vermis is small. We wait. Okay, this is 18 weeks. Same images. 32 weeks MR, 32 weeks ultrasound. The MR still saying perhaps something is wrong, but you see the ultrasound, the vermis is completely normal. Time after time after time. You will come and see by telephone or by sending some images. Professor Malinger, we have a fetus 15 weeks, 16 weeks with an abnormal cerebellum and a large cisterna magna and a large fourth ventricle. What is your diagnosis? Normal. The diagnosis is normal, because the chances that I will be correct are 98 to 99%. And all of them are different patients, all of them have normal vermis later on. And they may, whatever you see, large vermis is connected, not connected, you can see the additions or the false cerebelli that may have 1, 2, or 3, or 4, or 5 additions. Okay, wait. But only if this is an isolated finding. If this fetus has also no eyes, no mouth, no legs, don't wait. Okay, it's clear that you don't need to wait for that. Case 3. You have an idea what's that?
Normal. You said normal.
The cerebellum.
is this a malformation or an insult? Insult, very good. Why is an insult? Because you see here, these two bumps here, that are probably the result of some kind of thrombosis or ischemic, something like that. You see that there is choroid plexus in one side, okay, and the other side, the choroid plexus is not present, but you see here the portion of the what's called the Blake's pouch or whatever you want to call them, and what will be the prognosis, or in this case, what will be the greatest influence of the prognosis? The vermis. Okay, if you have an insult of the brain, you are sure that the vermis is normal, not now, you should wait, but if the vermis is normal, the prognosis is usually very good, because we have plasticity, and we can leave only one hemisphere of the cerebellum. Most of the children are completely normal. We have follow-ups because we don't perform abortion. You think that everything in Israel you perform abortion. No, in these cases we don't perform abortions if the vermis is normal. And we have 12 children that are developing very well. One of them is like Ravi, completely
Crazy.
hyperactive. This may be a big problem. Also, it was like that, and my mother always used to say, "We have very difficult years with you." It's not working. I don't know why. Okay, here again, we have a patient that has some kind of anomaly of the vermis, but also the lateral ventricles are quite dilated. The choroid plexus didn't look well, so this case may be the exception to say that something is wrong. And here, this is for you, Ravi. Perhaps you know these images. Okay, this is a transabdominal examination performed at 12 week. You see, also we know how to perform examination at 12 week. And we perform also TVS. The first row should have. Someone may make a diagnosis of a huge malformation in this fetus, or this fetus is more or less normal. Spell yourself. Who says it's normal? Who is willing to say no? You know that I'm going to cheat. Who think that it's abnormal? So it's abnormal. What is the diagnosis?
Well, I see that.
No. I was asking. Yeah, sure. You say it's abnormal. What? You. And okay, Katya.
Well, sometimes I got the feeling that there is a little discontinuity in the maxilla.
Look here. Apparently normal. Okay.
You didn't show it, sir.
Hmm?
You didn't show it.
I took these images in purpose because hundreds of years ago I come to London to see to the Mecca, and I went to the place. I put a clean shirt and with a skirt that we don't use in Israel, not cravat, and I went to the place. And I signed that I am not going to speak. I am able to take the wall and not let the wall fall, but not to speak, even if you see an abnormality. And the fellow was doing the examination, and the patient was referred because of abnormal nuchal translucency. And after 15 minutes of not seeing the meningocele, because the fetus was lying with the back to our side, and I decided to touch the fellow. And I told her, I need to go home. I want to tell you bye. So we went out and said, go back and look at the huge meningomyelocele. So these things might happen. Okay, sometimes you miss a very, very, very big problem. These things can happen. So, but again, yes, there is probably also a cleft there. Okay, this is the case. Okay, it's 16 weeks and 2 days. The measurements of the biparietal diameter are okay. The fetus, there is something particular here. I think no. It seems normal. Okay, look again. Normal measurements, no small BPD, no lateral ventricular dilatation. The shape of the brain is okay. The cisterna magna is present.
There is a little bit of lemon shape.
Wait. I can't. Where?
Third one.
There? I can correct it. Wait a minute. But look at the back. No, I'm not joking. This is because we use 16 to 9 instead of 4 to 3. So when you put the images from an old they go like this. But here we are. Okay, and the question again should be: is this a closed one? Most probably it's a closed one because this is why we don't have the signs and the cisterna magna is normal. But okay, now I am asking questions. Look here. We are at 17 weeks and 5 days, 9.2 millimeter. Are in this case the lateral ventricles normal, mildly dilated, severely dilated, or normal with choroid plexus pathology? Someone thinks it's normal, 9.2, normal? Wrong. Mildly dilated? Yes, because this is the exception. This is the exception. Early in pregnancy, before 22, 23 weeks, a lateral ventricle more that is 9 millimeter may be dilated, and particularly it's important to know that the choroid plexus, as I told you yesterday, the choroid plexus is dangling. So at this time, 9 millimeter choroid plexus dangling, suspect at least that the ventricles are dilated. The case was referred because of ventriculomegaly and a single umbilical artery. The diagnosis was made at 16. He came for a second opinion. The nuchal transduction was normal. The alpha fetoprotein was normal. And we were searching for a possible etiology. Look here and remember our lectures of today.
Yes.
Okay, in these images, the associated findings include agenesis of the corpus callosum. Most probably not, because you see the corpus callosum is there in the lower images. Okay, cerebellar hypoplasia. Okay, the TCD is a little bit small. That the cerebellum is a little bit small. Abnormal thalami in cerebellar hypoplasia. Okay, abnormal thalami. Look here. That there is not thalamus is only one, and most important that you recognize now because of the lecture is that here something is wrong, and yes, there is abnormal thalami and cerebellar hypoplasia plus the fornix. So the diagnosis is, as you told us, Katia. Thank you very much. the food is not yet ready.
Last case, not an early case, but we don't have very common cases, but this is a case we had together. By the way, she told me to tell her your regards, the lady. Yeah? And if you come to Berlin, we are both invited to dinner. So the doctor called me, I need an urgent appointment. It was the evening, you see here, 4 o'clock. Said, arriving because of ventriculomegaly. And the patient, this is very, very important, is from Israel actually. So, and I put the transducer and I had the shock. Because the doctor who was treating her, he's doing a good job actually, but he's not an expert, but so it is a brief presentation and not even Gustavo succeeded in turning the baby. So I saw ventriculomegaly and I found some fused lateral ventricle in the midline, no cavum septi pellucidi, and some egogenicity like bleeding. So, but you see here, this is absent, and this is here absent. But I missed for the bleedings I've seen in my life, I've seen some around 15 cases, that the parenchyma of the brain was still intact. So absent septum pellucidum, no holoprosencephaly here, but you don't know. And what I assumed, because I was looking also for the fornices, that due to the urgent ventriculomegaly, there is some vessel opening and there is an intraventricular bleeding in addition to the absent septum pellucidum. So it could be holoprosencephaly, it could be septo-optic dysplasia, it could be polymicrogyria, because this is often found in cases where absent septum pellucidum, and it could be something else. So this is the slide I use when I speak on absent septum pellucidum. It can be a normal variant, it can be SOD plus, it can be SOD or holoprosencephaly. So these are the images, and show you some video clips. You see here. Take another one. This one I showed you because I was looking for the optic chiasm, and you can see here, wait, this is where also you can look for it. Just under the, here. Should be here, yeah, but I'm not sure. I will prefer to, this is the volume to show that we have a corpus callosum here, but not very nice. This is a normal chiasma. I use even, this is 28 weeks. You can see this echogenic part. You see here? Like a butterfly, and the white dot is the adenohypophysis, sorry? Infundibulum, yes. But you see here, you can see it. In this case, I couldn't see any chiasma on this plane. Here, some part, but this part was not seen. And this is a video clip where I hardly was able to see anything. I saw some anterior parts. So for me, it could be something related to this condition, and secondary, you see here some anterior part, but I don't see the typical one I see. In general, if you have good scanning condition like this, you will see it. So we discussed.
If you are not sure, if you are not sure about if it's there or not, you should put color and look at the mid-cerebral artery. The moment that you see the mid-cerebral artery, what is in between is the chiasma. If it's there, you will see something echogenic. Yeah. If there is not, you will see fluid.
This is what I do in general. You go a little bit lower and you see an opposite. So I discussed with the patient and I told her, you are 33 weeks gestation. If we go through the whole discussion in Germany, we'll need at least 1-2 weeks until the committee and so on. And it's not easy, and you will have counseling. And I said, I have a good friend, and if you are from Israel, I will call him. So I called him in the evening. I told him, please, Gustavo, write me an official email that in case of, I can use it as a second opinion to hurry things. So, and this is the email he answered me. I'm writing to you after having reviewed. This is why it's very formal. You send me an allowing to telephone conversation with the patient, husband. The images of this 33 weeks demonstrate a very serious brain condition with extremely poor prognosis. Although difficult to give an exact etiologic, it could be semilobar holoprosencephaly and severe ventriculomegaly with falx disruption and brain damage following interventricular hemorrhage. The current image showing an unclefted thalamus is more suggestive or HPE, which is holoprosencephaly, should the patient decide to come and so on and so on. They came next morning. I was hoping to see more. I couldn't see and said, can we check later? That no, we have a plane at 10 o'clock to Israel. They flew to Gustavo, and this confirmed the hemorrhage as well. She went for termination. They checked also for some blood clotting things,
Nice.
but it was not successful because it clotted. So, and then I called the doctor, who was really, how to say, out of. He said it's not possible termination because, but I had a normal scan. That please send me all images you had because this absent septum pellucidum may have seen. So these are the images from the doctor at 21 weeks. You see the cavum septi, but you see the bleeding here, hemorrhage. You see the hemorrhage here. He had a doubt that there is something on measurement, but you know this is not so obvious if you are not doing a specialist scan every day. He had the impression that the brain. These are the measurements. But you see here the whole destruction. 23 weeks.
Wait, go back. At 23 weeks, you see the clots inside.
Yeah. It is there.
No.
Here.
There.
Yeah. But you know, we see it because you know what to look for. But let's say if you, this is you know, let's say at least he had stored images. The other, let's say, I swear it was normal. So in this case, I told her likely the bleeding could have been the reason, because it is not an anatomical problem. It is a bleeding destroying only the mid part of the brain and not into the ventricle. In general, what we see when we have an hemorrhage, we rarely see the disruption of the midline. We see more echogenic walls of the ventricular part. So she went for the platelet genotype, and you see here, this is of the woman, and this is the husband. He's heterozygote, and she's homozygote. So we knew it is HPA5 of the fetal alloimmune thrombocytopenia. And we did the next pregnancy an invasive procedure to rule out that the fetus is heterozygote and was homozygote, and she continued pregnancy. She had 50% chance that this happens. People I asked, let's say, having experience on this field, they say this group is very, very rarely associated with brain hemorrhage, less than 5%, but this is a case showing you that this is also possible. So in the list of the absent septum pellucidum, we should add also, let's say, brain bleeding, destroying the midline. Thank you, Gustavo. It was a nice case.
In these cases of a bleed, you always should ask the patient for even minor trauma, because sometimes a minor trauma to the belly may produce this kind of bleeding. Particularly, there are some blood dyscrasias that may be congenital, that may produce even after no severe trauma. And also you should consider there are a series of stillbirths published from the Caledonian Islands where there are this kind of bleeding were due to what's called traditional massage. That the husband gave the woman there traditional massage, and they have been reported long time ago, but usually there are subdural hematomas.
I didn't prepare. Professor Mallinger just asked me if I have another case, so this is in my computer. This is a woman that came to me at 13 weeks of gestation due to increased NT. You see that the NT is about 5 millimeters. You can see the enlarged cervical cyst. You can see the micrognathia. You can see the hemivertebra, a single pelvic kidney, hypoplastic nasal bone, and ambiguous genitalia. She came to me, although I'm lecturing about increased NT to scan before karyotype, she came to me after she has done a karyotype. And the karyotype was a male. And this you can see, this is an ambiguous genitalia. And she had also polydactyly, she had also short, long bones, and abnormal hands, and she had also ARSA. And here you can see the AV canal at almost 13 weeks of gestation. So anybody has an idea what the probable diagnosis is? Camptometric dysplasia is one possibility. Vactor is another possibility. But Vactor usually, I knew that you said Vactor, so I prepared the case of Vactor at the same gestational age. You can see at 13 weeks of gestation, this is at 11 plus 2. It adds many features like the case that I've shown, but it doesn't have ambiguous genitalia. It doesn't have the other feature that I've shown. Anybody else has an idea?
SLO.
I knew that you will pick up the diagnosis. Smith-Lemli-Yopitz. This is probably the first description of first trimester diagnosis of Smith-Lemli-Yopitz. And the Smith-Lemli-Yopitz is the combination. This is still the Vactor. You can see the hemivertebra, the kyphosis. And this is the Smith-Lemli-Yopitz syndrome. This is autosomal recessive syndrome, multiple malformation syndrome due to inborn error of cholesterol synthesis. Due to the shortness of time, this is I did a literature review, and there is no publication on first trimester diagnosis, and this is a very descriptive case of a rare condition, mainly in the first trimester.
So my second case for today is in a spontaneous dichorial diamniotic twin gestation, still in a patient with no medical history. At the first trimester morphological scan, that are the features for the twin A. At 15 weeks, still for the twin A, but unfortunately we have no information about the heart. And at 18 weeks and 6 days, the same twin was referred to us for a brain abnormality. But what about the heart? And later in gestation, at the second trimester morphological scan, for all the scans, the other twin were perfectly normal. It's not follow. No, it's a normal riding aorta. Because, sorry, that's the image for the aorta. Excuse me? Oh, you see it in the third picture above. Sorry. And we have no karyotype for this patient because she's very religious and need to. Yes. Right ventriculomegaly. Oh, maybe. Sorry. I don't think it's Epstein, or maybe at 18 weeks, maybe just a slight form of Epstein, because the valves are in the same plane. But yes, it's severe tricuspid dysplasia.
Can you show us the right outflow tract?
Oh, sorry, I don't have the image. Sorry, but it was no. They refuse. They refuse to take an amnio. But I always
I've seen
have.
Down syndrome with Epstein. It's not unusual, and the brain can be also.
Yes.
But do you have the measurement of the pulmonary artery?
Yes, it's pulmonary stenosis.
And it's a boy or girl?
It's a girl, both of them.
It's unlikely to be pulmonary stenosis because the shunt of the VST is from the left to the right. If you have pulmonary stenosis, you have high pressure on the right side, and it will be always from the
Otherwise.
right to the left. You see the blue is going to the right.
Well, you see that it's bidirectional because on top you see that it's also.
Excuse me? Was normal, perfectly normal.
If it's pulmonary stenosis, it will be one direction.
But the pulmonary is very small. It's very small. And the spill is.
There is a tricuspid.
Yes. Due to yes, I think it's severe tricuspid dysplasia. I don't think it's Epstein, maybe, because it's a wide spectrum. It is not Down.
Do you have
Maybe.
Do you have the profile of the fetus?
Yes, just a moment. I return for my first slide. That
Okay,
is,
but that was in the first trimester.
yes, at 11 weeks.
Okay. Looks okay.
And the ductus looks fine, and also no tricuspid regurgitation.
How do you know that this is the fetus of the echogenic?
With properly label. Okay.
Labeling. As Asma said.
So the pregnancy is ongoing now, is 23rd week. And I think for now I have this data of the normal first trimester morphological scan at 18 weeks, severe hydrocephaly, severe tricuspid regurgitation, dysplastic tricuspid valve, a large VSD, and pulmonary stenosis, secondary to the regurgitation. And at 21st weeks, also the pericardial effusion and the dilated right atrium.
Could be also trisomy 18.
Yes, I couldn't rule out any trisomy or something but I don't have the karyotype because they refused.
And it wasn't born yet.
No, it's 23rd week. No.
So next year you will tell us.
Maybe yes. Thank you.
Thank you.